kindly have sent their beautiful creations, and I want everyone to know, and Bernice, for you to know. I wear them more than just at these press conferences, and they make a difference in making sure that I am protecting my colleagues as to the highest degree that I can by taking seriously the requirement to wear a face covering. Now, as we do for all of these press conferences, it's very hard to hear us because you are muffled with a homemade mask. So what we do is we take them off while we're talking, and then all of us put it back on when we're not. And again, as a sign of respect for each other and as recognition that this is the requirement in a public health order, and it really does make a difference. So we're going to start like we do with the case updates, and we'll put it up on a slide for you. We have 121 new cases today. Now that's down from yesterday. We had 147 yesterday. I review the daily case rates. So does this whole team and the medical advisory team. Everyone who's working on this public health response, which is nearly everyone in the private sector who's a first responder and everyone in government. And the reason that's important to me is to sort of look at how the days shape up in response to any number of decisions. But I do want to remind everyone who's viewing that when Dr. Scrace talks about modeling, you have to have much more data over a much longer period of time to understand what it really means. Having lower cases today feels good, but is not an indication that we are free of COVID. And until we have 0 cases for a long period of time and a vaccine, we are not going to be free of COVID or COVID risks. Now that brings our total to 9,367. We have 189 individuals currently in the hospital. That's 8 lower today. 60 are on ventilators. That number is a good indicator that fewer people in the last day or so are on ventilators. Again, since we don't do these every couple of days anymore, for new viewers, you really want to make sure that your higher level of care and the anesthesia drugs and the ventilators, the equipment, is available to meet the needs of any patient anywhere in the state. So we track this carefully. Quite frankly, they track it carefully in the country. We have 420 individuals who have lost their lives to COVID-19. We have 10 new deaths. That is frankly a tragic number. Every death we mourn as a state, and we share and give our condolences to the families. Half of these individuals who lost their lives to COVID were in long-term care facilities where we know the conditions for the individuals living there are typically an indication that they have severe or significant chronic issues and disease factors. But nonetheless, it's a stark reminder about why it's so important that we get our strategies right and that we continue to work to prevent the transmission and the infection spread of COVID-19. In 1 minute, you're going to hear from Secretary Kathy Kunkel, but on my slide, it gives you the total tests conducted statewide. It's 250,880 tests. It is an incredible effort for a state this size with the competition for both staff and supplies and instruments. We want to continue to increase that the level of testing we do every day. And again, we're on the path to do that. We are still making improvements, and I'm grateful for that. And I'll go now to Secretary Kunkel. Will give you some more testing information. Thank you, Secretary.
Good afternoon. I think I have a slide. We're testing in the neighborhood where our 5,000 was our gating criteria. We easily hit 5,000. There are occasionally days when we're down in 4 over a holiday or if there's a shortage of swabs, but generally we're at the 5,000 or more all over across the state. We have several levels, as I've talked about, of intervention for testing. We do surveillance looking to diagnose the virus across 6 specific areas. We will respond to hotspots, but we also have the rapid response to positive COVID in the workplace. We've been doing this since May 11th when the state began to open up. Since then, we've had 119 rapid responses in 27 different industries or businesses. And just some examples are grocery stores, nursing homes, dental offices, financial institutions, dialysis centers, and child care centers. And I meant to represent that we're in all the businesses of the state. When we learn in the morning that there's been a positive, the Division of Epidemiology does contact tracing of the individual, but we at the Department of Health and our other secretaries will contact the business to let them know that they've had a positive worker. We help them close down the affected area. We test 100% of the affected employees, work with them to develop a COVID-safe plan, and arrange immediately for additional testing. Slide 2. We continue to have some hotspots that are of concern to the state. One of them is the Otero County Prison Facility in Chaparral. And to date, we've had 222 positive cases. 8 of our inmates are currently in the hospital and 1 is intubated. We've had 2 deaths from this facility. Our response has been very aggressive. In addition to testing all the staff, where there's been no additional cases, we test 25% every week, and we're quarantining and isolating the inmates and testing them every 3 to 4 days. And all unaffected units are also being tested weekly. Next slide. And this is long-term care data. This was our primary concern. We knew this was a really vulnerable population. We continue to test them carefully and frequently. The data here is that it's a little bit hard for me to see from over here, but in assisted livings, we have 4,439 individuals and 4,000 staff. You can see we had 69 positive staff and 30 deaths in assisted livings to date. In nursing homes, we have 5,315 individuals. We've had 379 test positive, or 7%. And total staff, 7,307. Of those, 264 have tested positive, with 130 deaths. The bottom line gives you the total number of individuals in both in the long-term care, which we considered both nursing homes and assisted living facilities, the staff, the number of deaths overall, which is 160, and last week alone we tested 5,748 staff. We continue to be aggressive in the nursing homes and in assisted living, both in response to new positives and when we are doing surveillance. That's all I have today. Thank you.
All right, thank you. And now we're going to go to a modeling update from Secretary Dr. Scrace.
Thank you very much, Governor. We're going to go over some data today, a couple new slides, new pieces of data, and I'll talk a little bit about some changes we're going to make and how we track things as well going forward. The first slide is a couple of maps of New Mexico. On the right, you have the new cases yesterday, and on the left, the total number of cases. A couple comments. Number one is that the cases and facilities in Otero County are not included in these particular maps, but you will see them in the totals that I'll show in a line graph in a little bit. The second is Mora and DeBaca still don't have cases as far as we know. And we're continuing to expand testing in areas with that we haven't had cases, but so far there's still 2 remaining counties. And then the gray swath you see going up from yesterday's map really represents that diagonal that we have across the state of frontier counties, very low population. So again, the heat map aspect of this, if you look at it, you can see both yesterday and over time that northwest corner of the state is still a big area for cases, high prevalence of cases, and also Doña Ana County as well. On the next slide, we've seen these before, and just a quick update, not too much has changed. On the left side, you can see the percent of total COVID cases that occur in those 10-year age bands. And one of the things we highlighted a couple weeks ago was the fact that we've got, and this week it's about 12.9% of all cases are occurring in children. That's high. I think we're now the 4th highest state in the country in terms of percent of cases. We're still really eager to get more data on disease transmission in children. Obviously, that has big implications for looking at reopening schools later this summer, and we're hoping that we get data from other countries that gives us more insight into what those dynamics are. Those of you who remember the H1N1 influenza epidemic in 2009 and 2010, children were major carriers of the virus and infecting others. So far, we have not seen as much of that around the world. There's one study from Iceland that suggests that maybe they aren't carriers, but we need a lot more data. That was very incomplete data. On the right, the green bar graph shows basically the chances of a fatality depending on your age group, with just very high numbers ranging 33% for people over 80 and into their 90s as well. And so we continue to watch those and monitor them. Another graph that I think is really interesting on the next slide that our epidemiology department has put together is they're able to take each individual census tract, and we have a fair amount of information about census tracts. I had a map of what a census tract map looked like for you, but we didn't have room for it on the slide. But I'm looking at one for Bernalillo County in the city of Albuquerque, and there's probably 50 or 60 different census tracts in that area. What this slide says is that if you live in a census tract or a small geographic area anywhere in New Mexico where 40% or more of individuals are at or below the federal poverty line, then your chances of contracting a COVID infection are about 15 times higher than folks who live in census tract areas that have less than 5% of folks with low income. And so we take a lot of, I certainly take for granted the resources I have, like running water and electricity and access to cleaning materials and things like that. Not everyone in New Mexico has that, and I'm sure everyone watching this broadcast is aware that New Mexico has one of the highest poverty rates in the country. And so this is something important to remember as we're trying to reach out to the public and intervene in different situations. This really is a matter of some of our most disadvantaged citizens being the most vulnerable to really serious illness. And so I wanted to, I really appreciate Dr. Smeltzer and Landon and others in epidemiology to put this together. We're continuing to track this as well. Now the slide that I had been pretty enthusiastic about ever since early May that I'm really, really concerned about today. And just to reorient you, or if you're new, on the y-axis we have the number of cases per day. And in order to make sense of this, we take a 7-day average, which means it smooths it out and we look like what was the average number of cases over the last 7 days. And I'm going to focus today mainly on the dotted blue line, which is all of New Mexico. And you can see this relatively rapid, what we call exponential rise in cases from our very first case on May 11th all the way up to about March 11th all the way up to May 1st. And then you can see sort of a plateauing that happened and then a drop. And we were very excited about that drop. It looks like things were coming together nicely. Our daily case rates were going down. And then unfortunately, over the past about 10 days, we've seen a fairly dramatic jump in the average number of daily cases. Now, some of that, a good amount of that is driven by the sort of light blue or turquoise or whatever color it is. I'm not the best with colors. Graph with the sharp uptake down below, which is southwestern New Mexico, and most of that is driven by Otero County and the changes in the correctional facilities there. But you can see too, the orange line, the Northwest has seen a little bit of an uptick as well. In part, this is likely due to reopening, and as you know, one thing I wanted to remind everyone about is that the virus doesn't change. The properties of the virus are constant. It's the human interactions and the intensity of those human interactions that cause these curves to go up and down. And so in addition to Otero County, we have seen an uptick in other parts of the state as well. And so we're watching this very closely. The Department of Health Rapid Response has been incredible in terms of getting into these facilities and testing and in other parts of the state as well. But as a result of this significant rise in cases, what used to be my favorite website, covidexitstrategy.org, where New Mexico had been green for a couple of weeks running, we've turned red. And you can see here, the reason is, even though we're doing great on testing and we're doing great in our ICU capacity, our cases have increased. And so we have to pace the whole process of reopening and more interactions with each other with what we're seeing happen in our community and in our state. And for me, this is a little bit, you could go to the next slide, actually, sorry, thank you very much. This was the website I was telling you about, COVID exit strategy, and you can see we're a bright red there and no longer green as we've been for weeks. So it means a little bit of a foot on the brake, watch carefully for the next couple weeks, not much in the way of major changes in what we're doing. And I think a constant reminder to all of us about wearing our mask, washing our hands, staying at home. Particularly don't go out at all if you're sick, unless it's to get medical care. And all of those things are critically important. This graph really, the previous graph is a graph of what we do. The virus is the same. It doesn't change. The more we get together, the more the virus spreads. Also to let you know, on the next slide, I'm going to get into the gating criteria. Now we have 4 categories of gating criteria. There's 6 items listed here, but this is a website now. You can go to that website or Google that website and you can check. We update the data 3 times a week. I'm going to walk through these very briefly with you today, but it shows how we're doing, and actually each of those blue links you can see there in the second column, you can click on it. We'll take you to the graphs of the data. This was a request at an early press conference. We're delighted to have it out there. It's generated a lot of good questions, and actually, as I'll talk about in a minute, it's generated some questions that are causing us to rethink the way we calculate rate of spread. So the 4 categories, there's 4 category 6 measures. First is rate of spread. I've already shown you the graph of the rate going back up. On Monday, we were at 1.1 with a target of 1.15, so we're still beating that criteria. Testing capacity, doing well. Secretary Kunkel, again, amazing job getting those resources out there. The numerical average to do a swab shortage a week and a half ago is 4652, but we're on a great pace. Contact tracing and isolation capacity, I've talked about a couple weeks. We are now getting automated data, which is great. We have the current status is that the mean number of hours it takes us once we get the positive test to reach an individual who's positive and isolate them is 25, very close to our 24-hour target. It's taking us longer than expected, the target being 36 hours. It's taking longer than expected to reach all the contacts and get them quarantined, so we're working on that as well. And a number of things in that regard are happening, very busy activity. 14 supervisors have been hired to do contact tracing in the Department of Health Epidemiology. They're being trained this week. Those are the supervisors. 24 contact tracers start next week. And then the plan is to bring on about 50 more per week until we're able to rapidly identify and contact individuals with a positive test and rapidly identify all other contacts and get everybody quarantined and in many cases tested as well to see where they stand. So good progress there in the whole process, and I think we're going to be seeing those numbers come down in the next couple of weeks as we add these contact tracing resources. And then lastly, the statewide health care system capacity. We measure in 2 ways. Do we have enough PPE in those 7 hub hospitals, which are sort of the central unit of our connecting all the parts of the state together. We've transferred over 450 people from different parts of the state to other parts of the state so they can have intensive care. That system is working great. We're really proud of it. And but at the same time, be aware that we actually are over our baseline ICU capacity. If we can put that same slide back up, you'll see that today actually, and that's not it. It's, I think, go back to the one before maybe. No, maybe they changed order. It's the dark blue one. But in my presentation, it's between this one and the next. But in any case, we have 278 people in ICU beds in the 7 hub hospitals around the state with a baseline capacity of 230. So we are actually 48 people over. Now, because we've done so much work on this, we have the capacity to go all the way to 460, but we have neighboring states, and I know the governor is going to mention this as well, who are really struggling right now. Arizona now looking at a crisis because their uptick in cases is overwhelming their delivery system. And so, again, a great shout out to Mike Richards and the team who've done such a good job pulling everyone together in the state and working together to create a almost seamless integration of those folks. PPE supply, we're doing well with as well. Now if we go to the next slide that has the little, no, not that one. It's COVID-19 rate of spread, NMDOH region target. So, no, you're going the wrong way. There we are. Good. Thank you. So I want to give you a little heads up on rate of spread. But first, let's go over the numbers. Our target is to get below 1.15. 1.15 gives us room to have a certain percent of additional cases without overwhelming the delivery system, about 15%. As we're on the downside of the curve, or at least the last 2 weeks, we're reevaluating the way we calculate that rate of spread, the R effective. And next week, I'll be back to you with a little bit more detail on how we're doing that and some proposed changes. The news is good, though. When we're on the downside of the curve, we are headed well below 1, and so we're going to make some changes in that. We have our mathematicians and epidemiologists and others working on this right now, so I don't have the data for you today, but we will be making some changes that'll bring some positive news and more accurately reflect the mathematics that go behind the spread rate. And also we'll adjust the target as well to the same it is now, really, that gives us a certain amount of capacity to expand. But you can see that all but the Southwest are doing well, and the Southwest driven by the cases in Otero facilities. Without it, however, I will mention Southwest was 1.13, so still just barely below the gaining criteria target of 1.15. Now we can go to the next slide, which has a bit of a green grid on it. And this is sort of the topic of the week, and I try to select the topic that I get the most emails about or that gets brought up the most. And you probably have all heard this. A lot of people just said, we should just do what Sweden did. They didn't really close anything down. They kept the economy running. They really just kept going, and their goal was to get everybody to get herd immunity, which, by the way, means getting 70, 80, 90% of your population immune. And so these numbers are small. You can review them later online, but what I've given you here, and thanks to Alex Castillo-Smith for pulling all this together, did a great job tracking down all the data, but you've got Sweden, Norway, and Finland, Sweden and its two neighbors, and then US and New Mexico data where we have it. And you can see that Sweden did open up and had about triple the number of cases of their neighbors, a little less than the United States, a little more than New Mexico. So that part worked. They opened up, more people got infected. However, 2.5 to 5 times as many people died per case as did their neighbors, and you can see they're almost double the United States and more than double New Mexico, so a much higher case fatality rate. And then on this idea that the economy really kept going, their employment rate skyrocketed as well, despite not formally shutting anything down, up to 10.1%, even higher than Finland, which did close down, similar to the United States and New Mexico. And then the coup de grace of all of this was they did all this in the hopes that they could get up to 70% of folks. And this experiment took place in Stockholm. Only 7.3% of people ended up being infected. And we don't even know if that means you have immunity yet. We're still waiting for the science on that. So this is my answer to the question just about the whole herd immunity issue. Is the experiment in Sweden did not really succeed. Some of us are old enough, maybe I might be the only one in the room, remember when a neighborhood kid had chicken's pox. We get marched over and spend like 15 minutes with them because we knew that we would get infected and get it over with. We don't know really how to think about that whole idea with COVID, but certainly in older people it has devastating consequences. And so we continue to watch this. We have a team that looks at all the literature from all over the world. Every other day they send out a big report of abstracts of everything. We're watching it all. We're hoping to get more data, as I mentioned earlier, on kids, so we have better advice on schools. So summary, next slide that says summary. Spread is improving below target, although we've had this rapid uptake, which means foot on the brake for a little bit, and encouraging all of you to continue to stay at home. Don't expand activities. Testing, not quite to our 7-day target, but when we have enough supplies, we clearly have the capacity. I explained contact tracing is being automated and expanded, and we think we'll have good numbers for you in the next couple of weeks. And we're doing well with the delivery system capacity. But again, the virus is the virus. It has not changed. Stay at home, wash your hands, clean surfaces, cough into a tissue or your elbow. You know the drill there. And then if you are going to go out in public, please wear a mask. Please wear a face covering. Multi-layer cloth masks recommended. And there's been some controversy. Some people pulled out a April 6th report from the World Health Organization that said that masks may not be necessary, and there's been a lot of publicity about that, despite the fact that there have been numerous good articles since April 6th that show that masks work and reduce deaths and reduce infection rates. Also, the World Health Organization, in a very unfortunate moment, came out with a statement earlier this week that there's not really any good evidence that asymptomatic people can spread COVID, which of course we did not know whether they could or not back in March when we had our first case. But now there's really good scientific evidence with very careful contact tracing and numerous examples of people who have spread COVID without symptoms. So remember that we wear that mask to protect other people from us in the event that we are infected and we don't know it. If we're infected and we know it, we should be at home, right? Staying at home and staying safe. And so, again, thanks to all the healthcare workers out there putting themselves on the front line. There's been other data I just wanted to address briefly, and then I'll finish on infections in healthcare workers. One article said they'd skyrocketed, and it turns out that over the past couple months, the infection rate in healthcare workers has gone from 7.8% to 9.5%, because the number of COVID cases in the population has also gone up as well. So this is a relative thing. We appreciate the healthcare workers being on the front line. And a healthcare worker, you also need to know, it's a very, very broad definition. How we keep track of it, it's not just doctors and nurses in hospitals. It includes workers in assisted living facilities and labs and other places associated with healthcare. So thanks again for your time and attention. Appreciate the questions you bring to us between these conferences. We're happy to always address the most common or popular ones. And I did want to take a little extra time today just to go through some of those things that have been in the news to make sure that you had the data that you needed to make responsible decisions about your own COVID-safe practices. Thank you. Back to you, Governor.
Thank you, Dr. Scrace. Okay. All right, so we want to make sure that we hit all the themes that we were talking about today. I've got another slide. There we go. So this is really an important aspect, and I fear that the general public, not just in New Mexico, but all around the country and the world, I think may get a little frustrated with us repeating that. But until there's a vaccine, we have to keep managing how we deal with the virus. And they are climbing in the U.S., and some of the public health experts are expecting, that we're going to double in the number of deaths by September and see steep inclines or steep increases in the number of cases across the country. And why is that problematic? Again, people go to the hospital, we overwhelm the healthcare system, the economy can't get safely reopened, and people died from COVID. So it is a very serious infection, and we have to treat it as such. So what we're trying to do is find ways, until there's a vaccine, to really manage our lives and the economy with a laser focus on the fact that we have an obligation and a duty to save lives. So we have to be very careful and be very vigilant. And I get asked this question more than anything. If a group petitions or a group comes to us, we are empathetic about your issues about opening up. But the focus is on the data about where we are in transmission rates, where we are in positivity rates as we test, what's going on in any region or sector of the state, what's going on with containment and containment strategies, and really where we are at protecting New Mexicans and keeping our healthcare system from being overwhelmed. So what are we watching? So a couple of our neighboring states opened up faster and in a more broader fashion than we did. All right, Texas, Arizona, California, quite frankly, Colorado did the same, but we're going to focus on these 3 states. Their cases are climbing, and Dr. Scray showed you, we've seen an uptick in cases. And so we have to analyze what that means, but for a couple of states, it's dramatic. So this week, Arizona has told their hospitals to activate their emergency plans. What are those emergency plans? Well, it depends on each state's capacity, but basically it says to hospitals that you can't do elective procedures, you can't see patients like you were normally, and of course we've opened that up in New Mexico, and you have to shift the way in which you identify and have staff assigned to ICU and critical care beds so that you can expand the number of patients you can see in a hospital. And while we do this safely, it is outside of the license framework for the number of patients we think is optimal based on the number of staff and the equipment in a hospital. So you don't want to go to an emergency plan. You want to prevent having to go to an emergency plan. And Arizona is, basically sounding the alarm. Next slide. I want to put this in perspective. So, because we don't, again, the medical advisory team's job isn't just to look at what's going on in New Mexico, but it's to look at what's going on around the world and to extrapolate data that's meaningful and relevant and evidence-based and apply it in meaningful ways to the decisions that we make here based on the actual data that's occurring in New Mexico. Now look at California. They've got 140,000 cases plus. They've got almost 5,000 deaths, and you can see the spike at the end of that bar chart. You can see the line where they're seeing increased cases, and you can take that right back and tie it to opening strategies and individual behaviors. And California is a state where they don't have a statewide or central public health system. So you can have an area or a city and a county, and their regions operate very differently, which makes it increasingly difficult because, again, people travel between these areas. So where you have a higher rate of spread, where you have a higher positivity rate, then the likelihood that you're moving that much faster, that virus, into areas where they had better control and better results gets minimized to a great degree. Look at Texas. 81,765 cases, nearly 2,000 deaths. They were really coming down. They were beginning again to have data that would indicate that they were ready to make some new sets of decisions. Well, and you make decisions. Why aren't the states in universal positions? Our populations are different. Our healthcare capacity is different. And the reality is the federal government failed to have a national strategy that allowed us to have equipment and testing supplies so that we could take the nuances of our populations and our states and our issues and then have a fair approach to making sure we could save lives and protect our citizens. So that's why it's a little bit different. But look, they had a decline. They opened up. Now look at that sharp increase in June as they've opened up their economy. And again, as a border state, this is both significant information for us as we look at what our initial increase and that, week worth of an upward tick and trend line, knowing we've got some risks in southwestern New Mexico and knowing that we still have issues in the northwestern region. This is troubling precedents, looking at both human behavior and what happens if you open too fast. And then look at Arizona. Now, Arizona is having the steepest incline Incline in June. They did a very broad-based sort of opening, didn't tear it up. Frankly, Texas did too. And I can't remember, and if one of the reporters asks us a question, I know that Dr. Scrace and my communications director will quickly tell me who opened up first. I want to say it was Texas, but let's take a look at that. But look at the steep incline in cases in June. Again, also you have some impacts not just on opening, but the behavior of individuals in each of these states, not picking on behaviors, but recognizing it has a role in what happens in your state. 29,000, almost 30,000 cases, and 1,000 deaths. So this evidence is dramatic, and it's something that gives all decision makers and all governors pause about where we are in reopening our economies. Next slide. All right, so again, we have to remain incredibly vigilant, and we've done well. I don't want to leave people feeling like it's hopeless, that even though we've got restaurants partially open, that you never get to go, that there's no way to be outside. The general rule still is, if you can work from home, you should. If you're sick, you have absolutely no reason to leave your house unless you need medical attention. That you should minimize the number of trips that you're taking out, that you should socially distance yourself, even when you're out exercising. And when I exercise, and I need to do more of that, because I'll tell you that in a COVID world, it's really challenging to get out of a 24-hour work cycle, and we all need to do that for our own behavioral health, but I always wear a mask, and I'd love to tell you that it's easy. It's challenging. It's a behavior that I'm adjusting to, and I know so many other Americans and New Mexicans are adjusting to that too. These decisions are not invitations to let up on your safe COVID practices. And I want to really harshly remind you again that when we do, people die. So on April 8th, we got asked a lot of questions because there was a widely cited University of Washington model, which the White House was using these models, that didn't quite capture the real data of each of the states, right? They didn't look at our healthcare capacity in the way that we hold the licenses. We know exactly who's there. They didn't look at the census poverty data. They didn't look at the minority data. They didn't look at a number, the aging data here. All of that has an impact on where you might be and the decisions that you make. How early you made decisions to close down, how early you had mandated social distancing and limit gatherings, all of that plays a role. Now, we've been identified in the way in which they're viewing national decisions as a proactive, assertive state early. Second, we have a couple of cases, we made decisions to begin to shut down the economy, to close schools, and to be really clear about COVID-safe practices. Now, on April 8th, the University of Washington projected 394 deaths, one death too many. And we talked about that we didn't want people to feel like, given the national numbers and the worldwide numbers of people lost, or again, the numbers of people lost to flu, where there's a vaccine and treatment, so it's a totally different environment, that number seemed not as bad as it certainly could be if we did really nothing, because we could just follow that projection and it looked like New Mexico was going to be okay. And that got modified in a number of ways. On May 31st, right, so a month and a half later, we've seen 356 deaths. One way to look at that is to say one model that we believe was way too optimistic, that we did enough, and it's really a way for me to thank you. Your patience, your diligence, something that's now really beginning to be harsh, which is we still have issues in long-term care facilities. Secretary Kunkel talked about that. We are very concerned about continuing spread, about managing that productively, and the number of deaths we report every single day that are residents of these long-term care facilities. We are not allowing family members to go in and minimizing even healthcare professionals from going in for routine evaluations. We are doing that by telehealth instead. That's really hard on family members. I know that unequivocally. My mother's in the hospital again because part of doing well in these facilities is having human interaction and impact. And knowing what my mom's risk factors are, I can be helpful to caregivers in that environment. So on the one hand, 356 deaths shows that we made tough decisions and it saved lives. On the other hand, it's too many. And if we let up, you can see these numbers like you're seeing in other states, where the number of cases nearly double every day, where you're in a situation where you've got extreme measures have to be taken in your hospitals and healthcare system, and where you have an escalating number of deaths related to COVID. So I wanted to make sure that we're really clear that these are much more than just a statistic, that we can stay the course, that people, I think, are feeling impatient and want us to just move forward in dramatic ways. We will move forward in opening and adjusting how we live in a COVID world by looking at trends in the data so that we can give you evidence-based decisions about where we are and why we can make those decisions, recognizing every time we introduce risk, we're likely to have more cases. That has proven to be true, and then it should level out again. And that's what we look for every time, so that we have a spike. I don't know if I love that term. We have increased cases, and it should return because people's behaviors and workplace COVID-safe practices are good. We level out. We level out for a period of time. We really pay attention. We don't want to lose anyone, right? We really work hard here. Then maybe it goes down a little. We make a decision, it'll go up, and this is going to be our lives. Could be up to 12 to 24 months until there's a safe vaccine that's readily available. We will have to keep doing this and making decisions accordingly, and we will. And New Mexicans should be very proud for doing your part. Although I can lecture you a little, you're still traveling too much, and we're still seeing areas where we're concerned about risk. Next slide. Okay. Even so, because the rate of infection is stable, and we hope to report, continuing to decline in areas where we need it to, we're announcing today what we are referring to as a soft opening for breweries. It's the same kind of strategy for restaurants, and this is why we call it a soft opening. We're amending the public health order so that starting tomorrow, outdoor patio seating at 50% occupancy for breweries. What does it mean? 6 feet apart, individuals, right? Social distancing. We want you to wear a mask when you go to a brewery in the same way I want you to wear a face covering when you go to a restaurant. We understand that, of course, you'll have to remove that in order to have what you're going to order and eat and your libation, support these craft beers. But we want you to be cautious and careful and help us. We believe that they can do this safely, or I wouldn't make this decision. And, we still feel very optimistic, even with the increased number of cases. Then on Monday, the public health order will be amended again, and it will allow 50% maximum occupancy for breweries indoors as well. Again, COVID-safe practices, 6 feet apart, social distancing, and I've identified all of those. They look very similar to the COVID-safe practices for restaurants. And so I'm pleased to announce this. It's another step. Allow people to support their local businesses, get you out of the house for your own mental health and well-being. Don't go to 10, go to 1. I don't think the breweries appreciate that messaging. It's not great advertising, but it really is consistent. We know our businesses are working hard to be safe. I have no doubt that every single New Mexico business is concerned about their employees. I have no doubt that the New Mexico public is clear that we have introduced risk. It's calculated, managed, prudently done, and now we wait. And we look at what the data says a week from today about where we are And remember that the real trend lines are 14 days worth of data. What's the magic about that, in addition to those trends, is that's really our social isolation, where we look at what the infection does in an individual and how long we want them to be isolated if you're not infected, but we want to make sure that you're not infected and you wouldn't be spreading. So those numbers all connect to the data points that we think are important to making decisions. Next slide. All right, so these are the same reminders, but I want to make sure that you have them. If the virus is anywhere, it can spread. It lives among us. It goes with you. Every time you leave the house, you have to take precautions because there's risk every single time. And we're clear. I know that you have to get medical attention. I know that you have to go to work. Those of you who have been in essential businesses, those of you who are now rejoining the workforce, you have to go to the grocery store. You have to go to the pharmacy. We're clear. Groups and gatherings are still unsafe. All right, so small, no more than 5. Please keep your physical distance and wear a face covering. And I get lots of positive reports and photos, and social media is full of very positive stories about New Mexicans really adhering, and I'm grateful to you. Positive reinforcement. There are plenty of New Mexicans who aren't wearing face coverings, and I have yet to be anywhere on any of my required outings where I don't see more than just a handful of individuals still without face coverings and in groups where they're not socially distancing themselves. And I continue to be concerned that those behaviors don't save lives. They don't protect our healthcare system and our healthcare workers. They don't protect our first responders, and they don't allow us to continue to safely reopen our businesses. So please work to adhere to these requirements. And, you know, New Mexico businesses in large part are adhering, but pay attention. And if they're not, don't support those businesses because you're not safe and you could put those workers in an unsafe situation. And let us know, and we will work to make sure that that business in short order is utilizing COVID-safe practices. And to the degree we're working hard, you know, not to carry a big stick, but rather to bring supplies and supports and training. But we will also hold businesses accountable who aren't protecting the public and their employees. It's really critical that we do that. Do I have a next slide? I can't remember. That's the last slide. I thought it was, but I want to make sure. All right, as we end, we're about ready for questions. It's mixed news, right? Mixed. We are holding our own. We're still identified, even though we're in the red in that United States map about where states are in their gating criteria. I'm actually still proud that we were the first to meet gating criteria. A lot of our gating criteria has been adopted by other states. That's all good in terms of creating a policy that works. Not great when individuals aren't helping us adhere to those policies, or we have containment or high-risk areas that we are absolutely responsible for, but create an issue where we have an uptick in cases and we have concerning potential situations. So wash your hands, wear a mask, don't leave unless you have to, socially distance yourself, only support businesses that are utilizing COVID-safe practices. And if we do all that, and we're all in this together, we're going to make it through this really challenging year. And as we do that, or a year and a half or 2 years, depending upon the availability of a reliable vaccine, we're going to be able to celebrate human kindness and respect, how everybody did more than their part, who businesses that stepped up, by individuals who are still donating time, energy, resources, money, food, to make sure that the most vulnerable among us are being fed every day, that we're supporting each other in any number of meaningful ways. That's the work that really makes a difference. New Mexico, let's keep doing that work. I appreciate you. All right, let's take questions, Nora.
Thank you, Governor. All right, folks, we're going to go to Julia Goldberg with the Santa Fe Reporter. Julia, you are unmuted. Go ahead and ask your question.
Thanks, Nora. You can hear me? right.
It's a little
Thank you.
happy dance going
Governor, I
on.
had a few questions. One, I just want to make sure that I'm clear. Breweries, but not bars, and perhaps you could just say why, so I don't make assumptions. And then I had a question about the data. COVIDtracking.com, which supplies the data for the COVID exit strategy website, grades states by the quality of their data. New Mexico currently has a C grade. We're only meeting about half of their criteria, they say, although I actually think it's a little bit more, but just not being reported in line lists and such. I'm wondering if there will, in fact, be more information added to the data dashboard. We were told last week perhaps county level information for recoveries would be added to that, and any other information that might be added as time goes on. I think that's it. Thank you.
No, the data is really important. Thank you for the question. I will defer to both cabinet secretaries. And when we adjust our dashboards and we also adjust to the required federal reporting, I do think there is some confusion. States don't report in the same way. Something that I hope to talk about next week because we're not quite ready to. I mean, we can talk about it today, but I'd like to be able to show the public how testing works, and now it's available in a different way in the private sector, both antibody testing and diagnostic testing. You've got, you meet your copay, or if it's covered, if it's not, you want to privately pay. But there's no requirement that they report to the state unless there's a positive. When they report to the state, they don't report it in a way that works when we communicate with labs. And then the way in which we report to our federal partners keeps changing all the time in this COVID world. And so you are exactly right. It doesn't quite roll up and capture right. We struggle with this all the time, particularly when I want to know about areas of risk, corrections, long-term care facilities, remote rural communities, sovereign nations who are remote rural communities, border areas, all of that. And so I'll make sure that our two partners are getting ready. So I get asked this question a lot, and I really appreciate it because it feels like, well, breweries are just like restaurants. You can get a drink at Chili's, that was an example that was given to me, and food. You can get a beer or drink a libation at a brewery, and you can often get food. So they're exactly the same. They're not exactly the same. I really looked to license, the number of people, right? It's that John Hopkins model. How long will you stay? What do we know about people's behavior? I mean this in not a negative way, but if you have a snack and the limit of 2 or 3 beers at a brewery, human behavior is a little different. So what we're trying to do here is every time we introduce risk, it's not kind of an apple for apple based on can I have a drink and can I order a food item, but rather it's what is the likely reason you're attending, how long will you be there, and what are the human behaviors that will be engaged so that we're managing the risk. So bars. All right, well, bars, people stay longer, they stay open later. I have a different dynamic about how people interact and behave in bars. And again, I don't want the viewers who are hearing this, watching this, to assume that these are opinions about behavior. It's just that that's why we go to a bar. It's a different environment and a different place for me to have access to entertainment. And we should be able to do that. So bars are later. They're identified in phase 2, risk behavior, duration, number of individuals, ability to socially distance. The longer people are out, there are all kinds of studies about human behavior. So again, I just want to make sure that as we open, it's safe. I get this all the time, and then I know it's a long answer, but people are really anxious. We don't want to lose any more businesses. I know that we do. I don't want people to have, these emotional behavioral health responses because they're feeling locked in. These are serious issues. They have serious health consequences, and we're paying attention to those as well, and we're concerned about them. I'm concerned about them. But having a fairness debate about what opens first doesn't work in the context of a pandemic. The entire pandemic is unfair. And it creates a situation where we have to calculate risk, introduce it successfully, make those decisions, and then we have to wait a period of time to see what happens as we've introduced that risk. And the last thing I'm going to say, by and large, most businesses have been kind, patient, helpful, in fact, there was a pizza place in downtown that just is going to close their doors. And in some of the statements that I saw on social media about this pizzeria, they really talked about how unfair the pandemic is. They did, and it would be fine to be upset at the decision makers. We can take it, although I don't like it when people get mad at my cabinet secretaries, get mad at me. It was really kind and compassionate about we all find ourselves in these unforeseen, dramatic, terrible set of circumstances. And blaming each other doesn't work, supporting each other and recognizing that there are real consequences. And I was really impressed by the way in which the owners talked about the situation that we find ourselves in. And I'm hoping there's going to be, a vehicle to get these businesses back up and running again. I really am. I really do. But that's the difference. The pandemic's unfair. COVID is unfair. Introducing risk, slow, prudent, safe, smart, looking at behavior, numbers of people, duration that they spend time there, and our ability to mitigate. That's how we make these decisions using that data and those criteria. Dr. Scrace, second part of the question. And then I don't know, Secretary Kunkel, if you okay.
Thank you, Julia. I did go to the website. I haven't been on it before. I'm reading through the criteria and for reporting, and I can find every single one of these metrics on our website, but apparently they can't. So it is true that some of what they're asking for is on the modeling team website rather than the county level or actually zip code level data that we provide. And so, thanks for the heads up on this. We'll get back to them, but I'm looking at all of them now, and of course we report the number of positive tests and the total number of tests. With simple subtraction, you can find out the number of negative tests. I don't know if we were dinged for that. Hospitalizations, treated in ICUs, ventilators, I see that every day myself. So we'll get back with them. Recovered patients, I know we report, that's online now. So anyway, one of them here is reported data broken down by patients' pre-existing conditions. I have not seen that one, but other than that, that's the only thing that I see that we're not doing. So thanks for the heads up, and we'll follow up on that.
I'm going to do two more things. Poor Julia, and it's unfair to everybody else asking a question, but Julia, two things. One, I'm going to take this as, New Mexico pride, so right on. We should get an A, and I'll put the MAT team and Dr. Scrace on that. I have actually some conflicting reactions. We do want to know about chronic issues and chronic diseases. We know that the mortality risks and rates are much higher, and it's something that we pay attention to, and it's something that the state is really working hard to mitigate transmission and risk, because we have so many New Mexicans who are far sicker because of our poverty levels and so many other issues and lack of access to health care than many of our neighboring states and other Americans, that we have to do a much better job living amongst this virus than everybody. Everybody should do the best job. But I mean, we really will lose too many New Mexicans, and it's unacceptable. But I worry that there are states and others who are reporting data in a way that tries to minimize COVID-19 related hospitalizations and mortality. And there's a national conversation about this, about whether one or more states, if you had a serious issue, if you were diabetic and had renal failure, then you couldn't have died of COVID. COVID was an exacerbating factor to the fact that you were going to die of renal disease. And so medical professionals and public health experts will continue to debate this. But my opinion is we should know every positive. We should know every COVID-related death. We should be clear about chronic and pre-existing condition risks, so we mitigate those. But we should not try to differentiate that we didn't lose as many people because of pre-existing conditions versus the opposite. This is a travesty any way we look at it until we get a vaccine. And so I'm conflicted about how people are debating this, but I leave it to the evidence-based experts to determine how you use that information. So thank you. Good conversation, Julia.
All right, next we're going to go to...
You have been watching Governor Lujan Grisham give us some coronavirus updates, and if you want to keep watching that, you can go to KOAT.com or the KOAT app. Now, the only real update of note so far during that briefing is regarding breweries. Starting Friday, they can open at 50% capacity outside only. Then on Monday, they can also...
First question I want to start with is New Mexico right now is one of the only states that is still maintaining that 14-day quarantine after air travel from all 50 states, including international locations. Other states are restricting or keeping those quarantines from places like New York and Connecticut. So when do we think that will change? And kind of following from that, in terms of the film production and film industry here, when do we think that will be able to start again? I think that ties a little bit into travel. And then finally, on the note of remdesivir, how much do we have of it? Are we using yet? And is it working?
I'm going to pivot on the second question to Dr. Scrace. We do. I can't remember the last shipment, so the number of doses, and yes, we're using it, and I'm going to make sure that the Matt is going to give us an up-to-date about allocations. And I don't know if you remember, we talked about it has to come to a particular research healthcare institution, UNM, and then we distribute it out to make sure that patients who meet the criteria and who can benefit from that treatment have an opportunity to have access to that drug regimen. So we'll go to that. I'm really being cautious about that 14 days. Remember, for out-of-state travelers, tourism is high risk, and this is how every state ended up with their first infection. It's a really tough spot to be in New Mexico, given the film industry and the fact that we are a tourism state. Now, we have clarified in our public health order and in our guidelines that folks who are traveling in for both what we call essential business and quick management, so averaging 3 days, say, we have removed the 14-day restriction. So folks who are traveling, coming in to do evaluations, say at the national labs, folks who are coming up to make sure that the management of recruitment and new films, as an example, that we're looking at that and that they're implementing their COVID-safe practices. It's waived. Waived's a strong word, but relaxed. For those folks, for shareholders and business meetings and boards and things that folks that cannot do it virtually, there's a reason that you have to be on site. We have already opened that up, and I think that that's been available for the last couple of weeks. And let's see what our data looks like. Phase 2, which, given the patterns and our strategies, would be available in July. That's when we should be looking at easing more of those travel restrictions, but they're high risk. And in phase 3 is when you don't worry about quarantining or isolation for travel or tourism or large gatherings. And that's not likely to be completely opened up in New Mexico. I hope it doesn't completely open up in the country until there's a vaccine. I personally, based on the data, think it's way too high risk. So, quick recap, because I'm long-winded, I apologize. July, the Recovery Council, again, remember, reviews where we are, what decisions we need to make, and they're required to also participate in reviewing the data. But that's what we're projecting still, some relaxing of the 14-day requirements for some business travelers. And film in particular was part of that relaxation. And I think that we're likely to experience in July some exciting news and exciting efforts in the film industry, who has been working worldwide on some of the best practices for COVID-safe practices. Dr. Scrace.
Thank you, Governor. We do have a lot of data on remdesivir. I'm hoping to improve our report card grade from a C up to at least a B+ just with this report. But so far we've received 1,650 vials. I'm not going to bore you with the distribution between powdered and liquid, but we prefer the powdered because it stores better and it's easier to transport. We've used 876 vials. We use 5 to 11 vials depending on how sick the patient is. Right now, our focus is on the sickest patients in intensive care units. So we've used 53%, which is actually good because if a course is 5 or 6 days and it's coming in every week, we're actually doing quite well. We were 21% utilization about 2 weeks ago. 14 hospitals are currently using it and set up to use it. And we are well aware that the distribution of remdesivir to the state is directly proportional and dependent on using it. And so our hub hospitals in particular, but also hospitals throughout the entire state have really gotten on board. I don't have data about whether it is quote unquote working here in New Mexico, but the literature now suggests that even though it's an investigational drug, that it shortens the course of illness by 4 days from 14 to 10 days. And this has generally been used in severely ill patients, and mortality rate is reduced substantially as well. I don't have those numbers in my head. If you send me an email, I can look them up and get back to you. So we're feeling really good about the whole process. We're feeling good about the distribution. Chris Emery has just championed this. He's the leader of this whole emergency operations team at the DOH part of that. And so we look at that about twice a week. And we believe that our use is actually keeping the flow of the drug coming into the state.
The next part of the question was about the film industry.
Okay.
From Brittany.
I think that July, I thought I answered that, Brittany. So I'm looking at Nora. I don't have anything to add. Film industry is included in how we relaxed, business travel, and we think that the COVID worldwide safe practices, maybe I wasn't very clear, I apologize, Brittany, and Nora. We think that there's some good, positive economic news that we'll be able to share in July that really talks about the ability of our current film industry to do more and to utilize incredible COVID-safe practices. And we know what kind of an impact they have on New Mexico's economy. And we are in constant touch with the film industry leadership about these issues in particular. So that's a shout out to the Economic Development Department and others who are engaged with folks directly, Universal, Netflix, and others.
Thank you, Governor. All right, folks, next we're going to go to Algernon Damassa with the Las Cruces Sun News. Algernon, you're unmuted. Go ahead and ask your question.
Thank you. Thank you, Governor and Secretaries. Obviously, the Otero County Prison Facility is a matter of great concern. We have one population of people in the custody of the State Corrections Department. We also have a population who are under the custody of the U.S. Marshals Service. Obviously, the state's ability to intervene in a private facility and among federal people in federal custody is limited. But what outreach are you making to the U.S. Marshals Service as well as to the private company that manages that facility? And also, are you considering any further measures to reduce the population on the state side of that facility? Using executive powers or legislative powers at your disposal?
I keep doing this. I'm going to go to the last part first. Where we have ultimate control and responsibility, we should have both. One of the dilemmas, and it's not preventing us from trying to figure it out, but it is very challenging in corrections to what's the placement plan. And do we have all of the community support systems in place to do that successfully? And I will tell you that this state doesn't. That's not an area that I am proud to talk about because we should be better. You might remember that we had any number, I've talked a little bit about them, criminal justice improvements and measures that we passed in the first legislative session after I was elected. I vetoed the probation and parole, which would help in this regard because there were some significant issues identified by the entire District Attorneys Association, and I asked that we work those out so that we would have a streamlined, clear system of support in corrections. We don't want to over-incarcerate. We want to make sure that we can productively provide parole and community reintegration, all of it. And now, with an emergency, you need those tools even more. And as you might remember, the probation and parole package that we agreed to didn't get over the finish line and upstairs, so that we've got new strategy. So it's a place of considerable frustration and challenge. Clear to us that we've been effective at mitigating in corrections. Again, it's not enough by being really, really narrow. Can't get in. We, as you recall, made everybody wear masks. We increased the way in which you could communicate by having unlimited telephone calls and telephonic reviews with their lawyers, and et cetera, so that you'd minimize risk. Tried to also manage how food, everything, supplies, medical care, everything. We couldn't get the federal side to do that. So we've written, I know of at least one letter. The reason I say that is I don't know whether we split it into a couple of different areas, both from an immigration standpoint and the other just from corrections operations. They didn't do any of those practices. We're living in a side-by-side world. Your failure to have decent practices, I think, in every possible way, created this kind of spread and risk in that facility. And, you know, we see the same kind of potential problems in Torrance County. So I'm very distraught, and so far the communication with the White House has not been what I would call responsive about strategies that would allow us to get them to do COVID safe practices, to minimize spread and risk. And I'm challenged by, as a state, about vehicles to think about ways to limit the corrections population and making those adjustments. And I'll give you an analogy that I do think has been meaningful but been far more challenging, and other states are now applying it, and I think they're finding it challenging. You know, we created a COVID nursing home, and the idea was early that you would have an individual COVID positive, move them out if they could be moved out. You got to be careful about transfer trauma, all of those issues. And where you could discharge folks who had been COVID in a hospital so that they finished their recovery process. It's working, but it's not enough for all of the issues to do productive containment. So we're still challenged. We're trying to figure those aspects out in the context of what we're seeing about states' responsibilities to be protective, to deal with racial inequities. It is something that, again, I'm looking at with a whole new lens, and I want to be very aggressive about. But I don't want to candy coat that this is a very challenging environment. And I think that we're going to have new best practices in corrections. And can I just do this? I hope that who's ever in the White House after November, and after the number of exposures and issues, give states a better and more clear opportunity to identify the requirements. And frankly, we need to really have another discussion about the for-profit prison industry, period, and for-profit detention in this country. And in an emergency and in a pandemic, it will give governors, including myself, far more opportunities to do better by and right by the individuals in our custody. Next question.
Thank you, Governor. Next, I'm going to go to Chris McKee with KRQE. Chris, you're unmuted. Go ahead and ask your question.
Thanks so much. I have a question regarding mass gathering. We're still limited to 5 people per gathering. This is kind of obviously a prime time. People are doing outdoor concerts, sporting events, normal pre-COVID.
Sorry, we're having it sounds like you're coming through a tunnel or something. It's very echoey. Can you get closer to the mic or something?
Can you hear me a little bit better now? Okay, you can just skip over it.
Me on text, I'll read it.
Thank you.
Okay, sure thing. All right, so next we're going to go to Dan Boyd with the Albuquerque Journal. Dan, you're unmuted. Go ahead and ask your question.
Yeah, good afternoon. Thank you, Governor and Secretaries, for the opportunity. Obviously, there's some trouble spots that you've talked about, Otero County Prison, the northwest part of the state. some of the group home living facilities, but I think there's also a narrative in the public that much of the rest of the state is, seeing declining caseloads and fairly safe. What's kind of your response to that? And do you think that's, kind of an acceptable attitude to have in other parts of the state?
I don't, and I want to be careful about that. Look, New Mexicans, in large part, I think, are doing their part. They're working to wear masks. They are trying to limit where they go. But even, I'm watching what's being written. Thank you, the New Mexican, and just the discussion even in Santa Fe. As things open up, you see the city come alive. You see an increase in the number of cases. What does that mean? Well, 1 day, 2 days, 4 days, it's not enough. We expect increases. But complacency when it feels like it's all right is exactly what creates more risk. And remember, in each of these communities where you've got the lowest, right? So let's take Mora County with not a single case. There are facilities right in neighboring San Miguel County that are high risk. A nursing home, too, and you've got board and care homes. I'm sure we've got more than one assisted living. I have to look up the numbers in that particular county, and we have the Behavioral Health Institute. We have to be really cautious. If we have a case get in, because you have more spread in the community, because we have more things open and it's too fast, then we create untenable risk for populations who don't have the same ability to make safe choices like we do, right? Food has to come in, workers have to come in, physicians and other folks and providers have to come in. So we want to lower transmission rates in every single community. And so I want to be careful. I'm proud of New Mexicans. I appreciate how hard this has been. I do. But moving too fast will give you the kind of unpredictability and potential emergency responses that other states are seeing. And the national experts are predicting incredible spikes related, frankly, to everything. Opening up, human behavior, not taking the COVID safe practices seriously, states not really enforcing that or working to really make that the standard, the protests, all of it are risk behaviors. So I want more longitudinal data, 7 and 14 days, really get a sense, get back to a flat or declining, and then we can safely reintroduce a little risk. So I appreciate the question. The message is, as long as the virus lives among us, there is unacceptable risk. So we have to manage it in the most acceptable, productive ways we can. Dr. Scrace.
Thank you, Governor. Just very briefly, Dan, I think 2 more quick points. One is that this changes from week to week and month to month. And a month ago, folks in the southwest part of the state were saying, hey, we're doing great. We want to open up more. And they still have a spread rate that's the highest in the state now, without including Otero County. And then the other point is that people move from place to place. And so while I can be confident that I haven't been to hotspots in New Mexico, a nursing home, a county, a prison facility. There's no way of knowing if the people that I see on the street have or not. And so unless we all agreed to sign an affidavit that we weren't going to travel at all, the comparison between higher rates and lower rates, based on our experience here in the state, has been very temporary and is always changing. Thank you.
Next question.
Thank you, Governor and Secretary. We're going to come back to Chris McKee with KRQE. I think we fixed our issue. Chris, you're unmuted. Go ahead and ask your question.
Cool. Thank you. I'm sorry about the earlier problem. Hopefully you can hear me better now. Okay. Thank you. Just wanted to ask a mass gatherings related question. Obviously, we're still limited at 5 people per gathering. This, of course, is the warm weather, prime time. People enjoy outdoors, concerts, sporting events right now. Of course, the New Mexico United, Albuquerque Isotopes are big things for people in the center of the state here. Their leagues obviously have control over games and such, but I guess I wanted to ask the general question, is the state seemingly on track at all to have any kind of sporting event, gatherings, or concerts this summer? We get questions about this so much, and I'm hoping that perhaps there's maybe a clear answer as to, do you think people will enjoy any kind of concerts, Isotopes games, or United games maybe this summer?
I think it is not very likely because the risk for having large gatherings introduces, right, nearly unmanageable risk and potential spread. And so that's, to the degree that we can minimize that, I think we should. Now, we continue to look at, could things change and we get to, large gatherings, which is phase 3, that we feel like we can get to an outbreak immediately, that we can minimize the rate of infection, that we can do effective contact tracing in such a way that we don't overwhelm the healthcare system if we had a large event. That's where you want to get, because it's going to take some time before we have a vaccine. I just don't see that as being June, July, and August. And I know that that's a painful message. There are things that people are still sort of waiting for localized and state decision making. And I know that one of those, which isn't quite a concert, but there's plenty of music options, and that's the Balloon Fiesta. So we're working with local decision makers and being open that things could really shift. And there may be a treatment design I'm unaware of, and it could be a lot of things. But today, if you ask me, do I think that in the middle of July that we can have a large concert? My reaction with what I know about COVID around the country and for the state of New Mexico is no, I don't think we can. And the other thing I just want to say to folks, I have limited authority, and that's a good thing. Some of that limited authority is with sovereign nations who have been really good partners. I can't tell New Mexicans whether sovereign nations will go to, larger concert-type outdoor gatherings or not. I want New Mexicans to know that I have recommended to them that they should not. And that, in fact, I think they're at much higher risk because a significant number of members, I'll do the surrounding Bernalillo County pueblos as an example, who many of them have incredible outdoor venues, indoor venues for entertainment and concerts, that a large degree, which is also a good thing, of those sovereign nations, tribal members work in those venues, which means they're moving potentially this virus back and forth. That includes gaming. And we've really worked hard to recommend that. I think June is too early. I'm still hopeful that the vast majority, if not all, will keep looking to phase 2 and phase 3 and look at much later openings in July and August or later. I can't guarantee what those independent decisions will be, but I want New Mexicans to know that based on our data and what we're asking folks that have to follow state rules, state laws, that is unsafe, not prudent, and impractical for making sure that we're minimizing the number of deaths in the state, minimizing the number of infections, therefore minimizing the number of hospitalizations. I know nobody wants to hear that. Dr. Scrace.
Yeah, I would just also add in here, I'm in complete agreement with the governor that if you look across the world, we've got numerous examples of what they call super spreader events, over 5,000 people infected in South Korea as a result of a series of church services, a carnival in Eisenberg County, Germany, 1,500 people infected, Mulhouse, France, 2,500 from a large gathering event, a ski resort in Austria between February and early March, 5,000 plus people infected. Now, our super spreader events in the United States so far have been more limited, and I think that's partly due to an immediate lockdown, but I talked previously about the choir practice where 53 people were infected from 1 2.5 hour event and 3 people died, and there have been others. There's been cases in Korea also of a single individual going from nightclub to nightclub infecting over 100 people. So that's what we have to hold in the balance against at least my own enthusiasm for going to an Isotopes game this summer with my family or my own enthusiasm to going to a United game. And so I just wanted to add that worldwide data. Fortunately, we haven't seen that kind of spread in the United States yet, but I think if we do open mass gatherings too widely and too soon, we most clearly will. Thank you.
Thank you, Governor and Secretaries. Next, we'll go to Matt Grubbs with New Mexico PBS. Matt, you're unmuted. Go ahead and ask your question.
Thanks very much, and thanks for your continued efforts on the technological side of this. Related to figuring out who has this disease and where it is, I know that Vitalant is doing antibody testing for blood donations. I'm wondering if others are doing that and if the state has access to it. And also, any more indication as to how often you want people who've returned to work to get tested for active coronavirus infection, and whether or not you can mandate coverage for multiple tests from insurance companies, or if the state can afford to cover those costs on its own. Thank you.
Thank you, Matt. These are all very important questions, and we are struggling with them right now. So the state received $77 million dedicated to ongoing testing. I can tell you unequivocally that's not going to be enough through a vaccine period. And so we're working with the federal government to determine what we're going to need, and all states are doing that. No state got enough. Before getting the $77 million and getting the CARES Act money into the state, we were using state resources, which we can now apply the federal CARES Act money to testing, and it's incredibly expensive. And just like PPE, personal protective equipment, the rush to get access to testing supplies, including now serology or antibody tests, is not a productive environment for this country. We're all trying to get it. We're all chasing it. Prices aren't stable, and now, the big commodity are swabs. And where swabs were relatively inconsequential in the context of collecting a sample from an individual for any number of tests or respiratory tests outside of COVID and early COVID, they are now incredibly expensive and in really short supply. So first question. We are concerned about that and are alerting legislators to that and alerting, most importantly, our congressional delegation. And I'm hoping that we're going to continue to see resources come to the state via the federal government and Congress. Two, as you know, because the state was engaged in the testing, we did not charge for that testing and stand by that decision and really expanded both Medicaid for making sure hospitals were getting what they needed to provide care and treatment to COVID individuals, extended that to essential workers like childcare workers. The goal was never to have someone who was experiencing out-of-pocket costs related to COVID. So we've been really working hard not to have that, because then people won't seek testing or treatment, and then we lose, right, the ability and our responsibility to manage outbreaks and spread. Last part of your question. And this is becoming very complicated. So on the one hand, I want New Mexicans to know that I think we should be expanding access to testing. And I really work closely but push hard, every governor is, with their departments of health. It's tough to figure out ways to expand, right, our testing footprints and to embrace that you can get a diagnostic test in a variety of places. Go to your urgent care. You too can get a diagnostic test for COVID for something like, on average, $100 is what that would cost you. You can go to CVS and get those tests. You can go, as you mentioned, to a number of places in the state for serology testing. Do I have antibodies? And then again, we want to know that because it tells us what the prevalence of the virus is. That's my non-evidence-based terminology. I'm going to get bossed around about that in about 10 minutes by Dr. Scrace. But it's important, valuable information as we return to work. But we don't know if you're immune, and if you are, for how long. So what's the problem then? Well, the problem is this, that as we expand access, and for folks who can and are willing to privately pay, and for providers who will say, if you'll get a test, right? And we know we'll pay for it or we'll minimize your copay, whatever those incentives are or aren't. The public health data requirement is only that you tell us about a positive COVID test. And the way in which you report that is not standardized by non-laboratories or folks who are clearly, engaged with us in infectious disease management, which is a public health issue. So all states, including this one, and I raised this with the White House, it's a great situation, it is, that we are making sure that we are creating access points in the ways that people get their health care, get their prescriptions, get their drug, get all their stuff. But you better be very careful that we don't create a situation where some people have access, some people don't, some people have coverage, some people don't. Some folks are then get surprise billing or increases in their insurance coverage, and some don't, and then I don't get any information, I being the state, so we know what's going on. And we are working right now on getting our arms around that, and you will likely see a refined public health order that both requires standardized reporting, so we know everything. I want to know how many tests, not just the positive. We want to know the negatives. We want to know serology. And we're working with the insurance superintendent to take a look at making sure that these are things in a pandemic that should, frankly, be covered. I don't have enough information to tell you that we've got the opportunities to make that occur in that way. As long as you come to the state, and as long as I'm in a position to fight with the federal government, I feel pretty confident that we're going to be able to manage making sure that COVID testing through the state and our partners is at no cost to the individual. But it is good news and bad news. And I think we're going to see issues about reporting and data all across the country as a result. And I can tell you it's interfering with the state's ability to get many of its commodities, swabs, sampling test tubes, reagents, and the antibody tests. So it's complicated our efforts, and that's no disrespect to our insurance companies or private partners. It's just complicating our efforts, and I appreciate your raising it for New Mexicans. And maybe we can focus a little bit on that for the next week and talk about where we are and what our supplies look like. So Matt, ask it again next week.
Thank you, Governor. Next, we'll go to Matthew Reichbach with New Mexico Political Report. Matt, you're unmuted. Go ahead and ask your question.
Hello, Governor and Secretaries. Thank you for doing this. My question was about voting. What proposals are you looking into regarding voting in November to avoid problems that we've seen in other states and some that we saw in New Mexico here in the primary and in November, and what is going to be a much higher turnout election?
Absolutely. And again, let's talk about, shout out to our county clerks and our Secretary of State, record primary turnout in New Mexico, even though it was tough, right? Because asking for an absentee ballot takes that initiative from the voter, which they did. I appreciate that. But with the vendor and mail, and we got too many ballots, we're still identifying and counting those right after the deadline. These are issues that are problematic because it does two things. It pushes people to the polls, which means we have a COVID risk. And two, it means that some voters, their voice was not counted or heard in this primary election, and that's untenable. So absolutely, we are working through a number of ideas, but it would be that in an emergency, we would be very careful to craft it so that it's related to this general election and COVID. So assuming that we're in the same position we're in today, no vaccine, no new treatments that make it last a day, and nobody goes to the hospital, and I'm being, I'm giving you an extreme positive hypothetical that no one believes will occur, that if conditions didn't warrant it, even with COVID, then maybe it's not a voting emergency. I don't see that currently, and most of us are expecting kind of a resurge in the fall, and so that's what I'm expecting. So given that, this legislation tied to COVID, Secretary of State then would have COVID emergency election powers. And those can include, right, having the county clerks mail out ballots. It can include making sure that we extend the time for counting our absentee ballots. Those are the two primary proposals. It might include some registration shifts just to make sure that we're getting everything as fairly identified as possible. But I expect to have election strategy on the call. I'm reluctant to tell you exactly what is in it because we have created a dynamic, which I'm proud of, with our House and Senate, minority and majority parties, where we're having conversations about what needs to be in the bill to make it work. We would still have polling sites available as well, but also what we would know meets the issues that are present today and has the kind of support that allows us to get it done in a limited special session. So they're working on those details. Legislation is being drafted. I am very confident that at least the things I've talked about with you today will be in that legislation, and then, of course, will be on the call. And I want to say thank you to the New Mexico legislature because these are significant shifts in how we do things and require lengthy debate with public participation. And so they are doing what they should do, which is treating this emergency as a real public health emergency and making decisions and shifts that protect New Mexicans and their right to vote. So good for the New Mexico State Legislature.
Thank you, Governor. Next, we'll go to Michael Gerstein with the Santa Fe New Mexican. Michael, you're unmuted. Go ahead and ask your question.
Hi, thank you. Governor, on the Otero County outbreak, you previously suggested that the outbreak there had more to do with problems in how the federal government hadn't instituted protocols to stem the spread soon enough. I'm wondering, now that we see it creeping north into state prisons, what is the state doing differently that the federal government did not do to make sure it doesn't spread to the entire prison system?
I mean, I pointed to the things that we did early that they wouldn't do, and I want to, I appreciate this, Matthew. I want to clarify. Unless there's a vaccine, there, and particularly with, we talk about face coverings, without a respirator type mask and PPE, there's no way to unequivocally say, I can't spread this if I bring it into a facility or a confined area or to another person. So what we did is mitigating strategies. And the point I was making is that in Otero County, you know, that risk is exacerbated when you've got COVID safe practices on one side and not COVID safe practices on another. And those are unfair risks. In any of these facilities, we have heightened risk issues. I want to go over those again because I don't want folks to assume that the COVID safe practices in and of themselves are enough. They are hugely proactive. They make a dramatic difference, but you are bringing in, workers have to come to work. They go home to their families. They go to the grocery store. They go to the gas station. They may be exposed by a family member who is a neighbor or came to visit at a child care facility because their kids are I mean, there are any number of ways that this virus travels. Food has to come in. Medical supplies have to come in. Even though we're really clear about visitation was stopped, unnecessary traffic inside a corrections facility all stopped, temperature taking, COVID safe practicing, enhanced hand washing, hand sanitizer, face coverings, including for inmates, all of that, and immediate confinement of an inmate or a staff worker. You know, worker, they got to go home, they stay home. They're immediately isolated. So I want to be careful. As long as the virus is in the state, and it is, and as long as it is in the country, and it is, and there's no vaccine, this virus is moving, and people are traveling. And so the point was that risk, in my opinion, was exacerbated by not having those COVID safe practices and having people in close proximity, easier spread. And we are concerned about it in every corrections facility. So what am I doing about it? We're doing aggressive testing, and I'll give you an example. Right? We do this surveillance. We do a percentage of the staff every week. We do a percentage of inmates every week so that we can get it contained, move people into isolation, move workers out. We don't just worry about people who are sick. Right? We're going after asymptomatic populations. That's not happening in any federal corrections facility. And in fact, the CDC, even with military installations, they're now agreeing that they should test asymptomatic populations by, having a surveillance strategy. Who travels the most? Who's the most risk? Where do we have critical staff issues? And yet I can't get DOD to actually have enough supplies to allow their bases to do what I refer to as surveillance. So we're out there trying to get to it so quick it doesn't have a chance to do widespread infections inside corrections. And we are also open to the possibilities that we could, discharge, and that's the wrong word, I'm using language for the healthcare, but that an inmate could be paroled. But again, it depends on the issues, it depends on the sentence, and it depends on whether there's any reliable community support and housing that would also be available and safe. And we do not have those infrastructures here. And that's something I'm interested in making sure for the next emergency that we build. And I think that I'm going to have a whole lot of partners who are interested in building a better system. But our surveillance, testing strategies, and isolation strategies, just those in and of themselves, are, I think, incredibly useful in making sure that we're protecting our inmate and corrections worker populations in the state. And I'm going to make a guess, and I might make the Matt try to make it not a guess. I would guess that most states are not actively doing the kind of surveillance that we're doing in corrections. And is that a reflection that I think states don't care about this population? No. But given that you really can't get the supplies, I think that they make really harsh, narrow decisions about where they're going to provide access to testing. We've been aggressive enough that we have supplies still. I mean, there's sometimes we have enough, and sometimes, you heard we can't get to 5,000, we only go to 4. But basically speaking, our supply chain's been fairly stable because we're all chasing those supplies, all of us, this table and about 20 other people every single day. But I'm going to guess that most states aren't paying attention there because they have limited access to testing supplies, so they're not included in their priorities. And we should double check all of the reports that states are bringing in and to see what their surveillance priorities are. So I looked away from the camera for a minute, and that was an indication to Dr. Scrace that he's going to have to figure that out by tomorrow. What time? 10 o'clock. Secretary Kunkel, I'm sorry.
Thank you, Governor. I would like to add, too, that the federal facility isn't doing anywhere near the testing that the Department of Health did. Department of Health gave that facility 500 test kits in spite of the fact that they are a precious commodity to us. And in our system now, all intakes are tested, and they go to one of 2 facilities, one for females, one for males. They only go to those facilities upon intake. They're tested. They're there for 14 days, and we test people when they leave. So I think that our strategy is comprehensive, and I don't see anything like that at the federal facility.
That was probably the most important bit of information that I completely forgot, is that we take seriously that we don't place an individual into a corrections facility without knowing that they're not COVID positive. And so I really appreciate that. And that has been also incredibly beneficial and aggressive strategy. So thank you very much, Secretary. I forgot all about that.
Thank you, Governor and Secretaries. Next, we'll go to Cedar Atanasio with the AP. Cedar, you are unmuted. Go ahead and ask your question.
Hi, thanks for the question. I'm actually going to reiterate my colleague Brittany Hope's question about the out-of-state travel quarantine requirements. Really, it's 3 small questions. The first one is, has there been any enforcement of this 14-day quarantine? And the second is, has there been any tracking? I understand that there hasn't been institutional tracking like Taiwan or Hawaii are with people coming from outside. But has it been stumbled upon by contact tracing? And then the last part of that is, if there isn't tracking, how are you evaluating the effectiveness of that out-of-state 2-week quarantine rule? People coming from outside.
So one easy way, I'm going to reject, did we stumble on it? We don't stumble on anything. Our contact tracing is an evidence-based strategy. And yes, we identify individuals that brought the virus in, or worse, take it out, right? We want to minimize spread. Easy places for us to be able to evaluate is the number of flights that come into the state and knowing who's actually flying in every day. And as you're aware, those have been greatly reduced. So we still have folks who are, and signage that tell people that they have to do a 2-week quarantine. Where we're able to enforce is by travelers who are coming into business. If they're tourists, you know, the option that we utilized for enforcement, because I don't have the authority to tell a flight they can't come in here. We did entertain trying to get the federal government to limit early in our efforts to stop transmission or mitigate it of COVID-19. Worked with Mayor Keller to think about ways to minimize air traffic coming into the airport, and it's a federal decision. And as you are aware, the federal decision making for states like ours wasn't as, in my opinion, productive or proactive, frankly, as it should have been. So where we track it and how we deal with it is, you know, that tourism wasn't available. There was no place to stay. You couldn't go to a restaurant. You can't go to a venue. So you really minimize that. But we still tell travelers, right, that they have to do a 2-week quarantine. And I know that it's still an issue because we ask people to lift it. So I think by and large, businesses, communities that focus on tourism have really held to that. Are there areas where we know that there have been some issues? Absolutely. Private planes that come in into a variety of locations and airports. Can I tell you unequivocally that every person that we ask to stay home, even if they didn't travel here, stays home for 14 days, unless it's under a court order. We are really working on your goodwill, but we can see in contact tracing if you didn't, by virtue of the people who said they came into contact with you and where. Those are the tools that we use. I think what you really wanted to know is, why aren't we requiring, you know, some other more specific tracking? And the easy, frankly, answer is it's really hard to require that of non-residents of your state, really hard to get access to them. And two, we don't have, and we're just now getting, right, the data systems that are more digitized and automated to figure out contact tracing. Because we weren't, the federal government didn't participate in a national strategy for a pandemic, which is why we are now going to that kind of a system. So it would be nearly impossible to implement in the early phases of our efforts to limit COVID-19 spread. But it's a very good question. And it's one of those areas that you do best by the decisions of what you open, another way to mitigate risk. And we really focus on relying on people's productive behavior. I am sure there have been a circumstance or two where it didn't work out the way in which we intended it to. I am positive about that. That's just human nature.
Thank you, Governor. And it looks like this will be our last question. Go to Dominic Aragon with the Gallup Sun. Dominic, you're unmuted. Go ahead and ask your question.
Thank you, Governor. Thank you, everybody, for taking questions today. Just two really quick questions. Number one, wanted, Governor, to get your thoughts. There is a research paper out by some scientists at the Gwinnett College whose research says that Navajo and indigenous tribes may be more susceptible to COVID-19. So just wanted to get your thoughts on that. And number two, forgive me if this has already been brought up or has been addressed at a prior time, but the Department of Health website where you can track by zip code on how many cases there are across the state, is there any plan to implement how many are active, how many are hospitalized, et cetera, any of those additional numbers that would be added to that website? Thank you.
I'll do that. So I've been, and again, I am not a clinician, I am not a scientist, and I'm not a researcher. I was very concerned about the potential for this virus to have a higher mortality rate for indigenous populations, largely for the reasons that we talk about, socioeconomic and rural aspects, right? If you don't have running water or access to health care, and you're living in multi-generational households with a single bathroom and very small living spaces so that you can't really self-quarantine yourself. These are high-risk issues. And what I believe to be the case, which Dr. Scrace will double check, is that what we learned after H1N1 is that indigenous populations had a 4 times higher mortality rate than other populations. So I've been really worried that we're going to learn that through the progression of this infection. And that's a huge risk factor. I used that risk factor tied to H1N1, certainly in conversations with our partners, all the governors and presidents of our tribal nations, to really talk about really significant reduction in risk strategies. And some pueblos basically shut down entirely, nobody in, nobody out. And I think it really did pay off because the risks are higher. I don't know that we have specific data that shows that this is exactly like H1N1 4 times, whether it's a little bit lower, a little bit higher, but I'm concerned about a number of factors, again, tied to chronic illness and socioeconomic issues that just create broader risk. And it's an area that we have been working diligently with our tribal leaders to get our arms around and the federal government's attention to, and Indian Health Service. Do you want to follow up on that, Dr. Scrace?
I was looking for a report. I'm having trouble finding it right now, but it's absolutely no question that the infection rate among those in the Navajo Nation is the highest of any in the state. And with extensive testing, and if you just look at the case counts, you can see, at least in the northwest part of the state, that half of the cases are there. And then if you look at the Navajo Nation published data, it's about twice what we're seeing here in New Mexico. Interestingly, though, and I'm speaking from memory here, which I hesitate to do, but actually the mortality rate for Navajo individuals with COVID infection is not higher. The highest mortality rate is actually in white individuals, and part of the belief of that is that a higher percent of white individuals live in nursing facilities and are the ones who are dying. So I agree with the governor that based on those two dynamics, unlike H1N1 where the mortality rate was 4 times higher in Navajo Nation, with a level or even with other people mortality rate, that this may be due to more socioeconomic factors, multi-generational families and the like. So we don't know, and I know the Navajo Nation is looking at that intently as well. We'll rely on their data for that, but so far a higher mortality rate is not the case, and so we'll wait and see what the data shows and what we get from the nation as well. Thank you.
Right. You know, this is what we do all the time, and I'll go to Secretary Kunkel about the dashboard, because we have the ability to do any number of things on the dashboard. You should know that I often shift based on the questions that you ask about what people are interested in seeing, which is for data scientists, makes them a bit I don't know that they appreciate my interest in learning about data and working to be a statistician. But we do have the ability to do any number of things and try to do that in response to what the public is interested, more than what we have to see every day and have to report to the feds. I'm going to push back on Dr. Scrace. Over the next year, when we really start to look at different population sectors, and we want to be wrong. I mean, because otherwise we've got risk in areas that we should be worrying about. And I've used that H1N1 mortality rate to push hard on Indian Health Service and to push hard on the federal government. Our sovereign nation leaders have done tons on their own to really work on these issues. To their credit, I'm really proud of them. But if you were to take out the nursing home population and you did a comparison, age breakout, and then mortality rates, you might see that there's a higher mortality rate for indigenous populations. In the same way that we're seeing a higher mortality rate among minority populations in other states, including our African American populations. And then you need to look at what are the factors. Well, largely they're still socioeconomic, but my interest in knowing as much as we need to know, because we can save lives and we get the right experts in the right places, is to really determine. And we've got labs looking at a variety of issues, right? Are there genetic issues that we need to know about? Are there blood type issues, genetic issues, that we need to be concerned about that make you more or less at risk of both getting the infection and or being hospitalized with the infection, more than the obvious, right? If you've got chronic conditions, we know that this is to a much higher degree, a much higher risk for hospitalization and ICU and ventilator care and potentially not being able to recover. So I think that it's, I'm interested in making sure New Mexico participates in doing as much of the heavy lifting for that data so that we can really understand it and do everything we can for every infectious disease issue to protect every single New Mexican to the highest degree. But now you see what happens every day at 2 o'clock. Our meetings take way too long because we disagree about how you look at the data, and then they make sure that my questions get answered, but that it's data that's being managed and evaluated by data experts. Secretary Kunkel, do you have anything to add about the dashboard in our last question? All right, but we can add those. I mean, we are collecting a ton of data, and we should. And we will add areas that are useful to everyone who's helping us get the message out. So New Mexicans, another long conference. I hope you don't mind. Doing them once a week means they're a bit longer. We're looking forward, I am, to the special session next week. We're going to make sure that we can continue to support our first responders and our healthcare workers and our education workers, and make sure that we don't have massive layoffs and furloughs, and I think have strong mechanisms to reinvest